you have any evidence of steatosis in the liver, together with at least one of the other 5 cardiometabolic markers, then you can say that you probably have MAS LD. Prevalence estimates around the world are as above. Long story short, that is a lot of stuff. Long story short, MAS LD is definitely increasing in prevalence across the world. Initially, it was thought to be more of a Western thing, but that's not the case. Lifestyle changes and industrialization are moving MAS LD all around across the board. And it is actually estimated that Africa and the other so-called third world areas might actually surpass the industrialized countries at some point in time. But that's an evolution of the nomenclature of MAS LD. We've moved from metabolic hepatitis to fatty liver disease, all the way now to where we are with MAS LD. At the end of the day, the criteria doesn't change, it's just the name that keeps on changing. Who knows what it's going to be called in the year 2060, as 2060 has become a famous thing. For those who are not Kenyans, they might not get it. The rest of us would probably get the idea. It's called kicking the can down the road because 2030 didn't work out. So the algorithm guide to phenotyping of steatotic liver diseases is as follows. So if you have a patient who you suspect has a steatotic liver disease and you've confirmed it by either ultrasound or any other methodology, then now you go now to trying to figure out what are the other metabolic criteria. It's either yes or no. If you do have metabolic criteria, then you have to first figure out, is there any alcohol consumption? If there is a little bit of alcohol consumption, then you have to calculate the amount of alcohol consumption that the person is having. If it's more than 50 grams per day or 60 grams per day for a man, then that patient has more of a combination of both metabolic as well as alcoholic liver disease together. If it is a very, very high amount of alcohol, then we usually say that you now put the patient on a criteria of generally alcoholic related liver disease. I'm sorry that the pointer is not working. If there's no history of alcohol consumption, which is on the right hand side there, then you have to now first of all knock off other possible causes of steatosis, either drug-induced monogenic diseases or you have cryptogenic steatotic liver diseases. On the other side, if you have no alcohol consumption at all, then that takes us to the topic of the day. Then you can have the patient being labeled as having metabolic dysfunction associated steatotic liver disease. Yeah, so that whole algorithm reminds me of this. It's a bit confusing. Like this is a very good question for a guy who wants to be a millionaire. So nobody's sure who's blocking the Strait of Hormuz. Is it the US? Is it Trump? Or is it the Iranians? Or is it both? Or is it none of them? So this is the spectrum generally of metabolic dysfunction associated steatotic liver disease. It's a spectrum of how things move. So you have the initial stages where you have less than 5% of fat in your liver. Then you move on now to when you have 15 to 30% of fat. That's when now you're having steatosis. Then the next stage is now where you have inflammation of the hepatocytes because of the ballooning and the fat vacuoles in the liver, where now we call it MASH. That's metabolic associated steatohepatitis. From there now, if things continue, inflammation continues, then you end up with now cirrhosis, and unfortunately, the last stage where you now end up with hepatocellular carcinoma. So the first 3 or so stages are quite reversible. The initial stage of steatosis, fatty liver changes, as well as steatohepatitis. Those are all reversible processes. The problem is now in the later stages of cirrhosis and hepatocellular carcinoma, those areas now become unfortunately irreversible. Pathogenesis at the cellular level is a bit complicated, but long story short, basically is about increased fat droplets in the liver parenchyma, which now end up ballooning and causing inflammation. Inflammation now ends up with scarring and fibrosis of the tissue, and that's how you end up moving into a chronic inflammatory state, which causes inflammation and you end up in cirrhotic changes of the liver. When you've confirmed that the patient has MAS LD, this is now a management algorithm. It cuts across a lot of specialties, and many hospitals are working together in terms of groups. The diabetologist, the obesity specialist, the gastroenterologist, all of us have a role to play, and the nutritionist as well. We all have a role to play in terms of the overall management of our patients who have MAS LD.